Dr Ashok Sharma from Chandigarh. Tips and tricks for removal of deep stromal foreign bodies.
Good morning, everybody. From chemical injuries, we move on to the mechanical injuries, and we all are aware that the corneal foreign bodies is a most frequent problem all of us encounter. But unfortunately, the deep intrastromal corneal foreign bodies are relatively rare, and we get cases in which all the removal have been tried. To manage these deep corneal foreign bodies, we need to ascertain the plane of the foreign body. So we have to have the detailed slit lamp biomicroscopy, and these days we can also do the anterior segment OCT. And depending upon the level of the foreign body, sometimes if we have to do surgical intervention like lamellar pocket and then removal, we have to decide that. Anterior segment OCT is very handy. This is the first picture is pre-op metallic foreign body in one of our patients. The second one is after the removal, and third one is a caterpillar here in the corneal foreign body. So anterior segment OCT gives great details and helps in the management. Now I will be showing 4 cases which we have managed. The first one patient is a 9-year-old girl. She presented to us after falling on a bush, and presentation was after 3 days. And this foreign body was in the anterior stroma only. It was lying horizontally. So the management is simple, that you just de-roof, remove the foreign body, and give the topical antibiotics and antifungals. And the patient was like, because it was off visual axis, the visual result was also better. Now I move on to some of more interesting and more challenging cases. Now this patient had a wooden foreign body which was in the anterior and mid stroma, and it was very difficult because wooden foreign bodies we have to remove in toto, otherwise there is no use, because residual wooden foreign body will lead to fungal infection. So we thought we will widen the track, and we may put some visco or some BSS and it may float out, which is not possible. So idea struck that we have retinal foreign body forceps which our retina colleagues used to remove intraocular foreign bodies. I introduced one limb of this foreign body forceps and engaged this foreign body into the concavity of this forceps, and taking care not to let it go out and break, we removed it in toto. Care should be that once you are removing, you keep on pressing the foreign body onto the anterior stromal layer so that it doesn't come out of that concavity. The next case in patient you will see is more challenging. We have a young patient who again fell on a bush, and he had 3 vertically oriented wooden foreign bodies, and they were up to deep stroma. There was no way to remove them from externally, so we thought we'll go for the combined approach for these corneal foreign bodies. We had at that time no special instrument designed to it, but we can also design it. But in this patient, since we decided in the OT only that somehow we have to remove, so we entered into the AC. You can see the head of all the 3 wooden foreign bodies which are vertically there. So after filling viscoelastic into the anterior chamber, we thought we'll press from the inside, and the stroma will be compressed, and then we will be able to remove these foreign bodies. So this method we tried in these foreign bodies, and you can see once introduced, we are going to press from behind, and the stroma will be compressed, so we can pick up the foreign bodies one by one. This is the first one. Now this is the second foreign body. And now this is the third foreign body. Since this was our first case, after that we have refined the process. We can always bend the cannula, or we can also use a silicone tipped cannula which our retina colleagues they use. So this method was very useful to remove these vertically oriented stromal foreign bodies which otherwise would not have been possible. After removing these full thickness foreign bodies, it is always better to check for the intraocular penetration, and in this patient, once we checked, there was intraocular penetration, perforation. So we applied synovial tissue adhesive in this patient, and it virtually healed without any problem. So it is always important in case of wooden foreign bodies that we remove them at the earliest and in toto, and also give these patients antibacterial and antifungal drops prophylactically. The simple way of putting the tissue adhesive, only care we take is we apply the minimum adhesive and we remove the epithelium. Since in this patient we had no corneal ulceration, nothing, so we used glue only to remove the epithelium. The first time we applied the glue, we removed the glue so that the epithelial debridement occurs, and second time we applied little bit of glue, and then the things are taken care of. The minimum possible glue which seals the perforation is required. Excessive you can always soak out with the cellulose sponge or with the cotton. So, sorry. We have the third case. Now, in this patient, we had metallic fawn body, and we thought we have a lot of experience, we will remove it externally. But you see, I was holding the fawn body, but was not able to pull it out of the stroma. And the reason I will explain later. So we thought we will widen it, and we may go the same way as we remove the vertically oriented fawn bodies. We will try to push it from behind, and we will remove that. So after filling the anterior chamber, now we had also become wiser that will not use like iris repositor that is a broad end and it does touch the larger area of the corneal endothelium. Although in that patient we didn't get any endothelial decompensation, patient is still with us, and we bent the cannula and we tried to remove the fawn body. So this attempt also was not successful. This was not successful by internal and external technique, and in this maneuver now you can see the cannula tip, but there is no fawn body. With this maneuver the fawn body has gone into the anterior chamber, and then you can see the fawn body lying on the lens itself at the margin of the pupil. And again for this fawn body retinal forceps came handy. And with the retinal forceps, taking care not to injure the lens and not to entangle the fawn body in the iris, we removed it. This fawn body was a metallic fawn body, and this you can see the irregular edges of the fawn body. So this was the reason we were not able to pull it out through the stroma, although we increased the incision and we tried that way. In this one we have to be careful that we don't engage the iris or don't injure the lens. We can go slowly and we can remove that. You can see the fawn body now. So these were the 4 cases. The first one is this one. We could publish this in IGO, and the second one also we have published. The third one we have already finalized the manuscript and we published it. So in the end I would like to say that for deep wooden fawn bodies the total removal at the earliest is desired. Small fawn bodies, wooden particles, and in the anterior middle stroma we can use the scoop technique using the retinal fawn body forceps. Horizontal wooden fawn bodies, deroofing technique is useful. And for vertically oriented full thickness fawn bodies, we need to use combined intracameral and intracorneal approach. And cyanoacrylate tissue adhesive is required for corneal perforations. Prophylactic antibacterial and antifungal treatment is desirable. Thank you.
Thank you, sir. Very nice presentation. We have learned from what you have shown.